Good afternoon. Now, since Dr. Aarti has already given all the information about epidemiology and the magnitude of HIV-TB co-infection and how the two programs are integrated. So this HIV-TB integrated program, the main objectives of integrated program is to reduce the burden of HIV amongst TB and vice versa. That is to reduce the burden of tuberculosis in PLHIV. There are four strategies which include preventive activities in the form of IPT prophylaxis, early detection, prompt treatment, and management of TB HIV cases in special situations. Now, for this, the one-stop service model has been formulated and which mainly looks upon TB services for PLHIV and HIV AIDS services for presumptive tuberculosis cases. What is this one-stop service model? It includes first is to diagnosis of tuberculosis by using CB-NAT after four symptom questionnaire. The CB-NAT within the same health facility. Initiation of daily anti-tubercular treatment at ART center. TB infection control measures and TB preventive therapy at ART centers. Not only this, but recording and reporting at the same center, that is ART center, which is followed in almost all ART centers in India. Now, how these TB services are given? It is clearly shown in the flow chart for PLHIV. The symptom screening, that is 4 symptom screening is done in ART center. 4 symptom screen, if it is positive, then diagnosis is done by CB-NAT. TB, if it is detected, then patient is simultaneously immediately started on anti-tubercular treatment followed by ART. If 4 symptom screen is negative, then they are provided with IPT prophylaxis. Now, if CB-NAT is negative for symptom screen, even they are also, if there is no CB-NAT is negative, they are also being given IPT. Now, what is this intensified case finding, which is very important? Now, integrated counseling and testing is done simultaneously in ART center. 4 symptom questionnaire is which is followed by which is following the pre-test and post-test counseling, HIV counseling. So patients, when they come, they are simultaneously counseled for 4 symptoms for tuberculosis. At ART centers, 93% patients were screened for tuberculosis at ART center. 6% had presumptive tuberculosis, and 12% were diagnosed to have tuberculosis with PLHIV. This is in 2019 data. Now, tuberculosis preventive treatment, which forms a very important point in the integration for PLHIV. There are the goals which are to be achieved. Only 36% of population has achieved this goal worldwide. However, India has reached the 43%. So India is ahead of other countries, especially from IPT point of view. Now, what is the progress of TB HIV services, additional services? That is co-location of direct microscopy centers. 89% has been achieved. HIV TB co-infected on co-triamcinolone preventive therapy, 93%, and TB HIV co-infected on ART, 89%. Now, there are TB services are also required for vulnerable population who are PLHIV, which includes female sex workers, MSM, IV drug abusers, transgenders, migrants, and truckers. Special mention is needed for prisons because in prison, the prisoners which are there, they have ventilation is not proper and therefore they are vulnerable for tuberculosis. So the number of patients, prisoners which are screened and how many are positive shown in the slide clearly. I will not go into the details. The challenges now, very important point about, in spite of TB HIV integration, there are still challenges which we have to face. Since India is the first and the commonest or highest having capacity, highest number of tuberculosis in HIV, there is an increased workload which makes the intensified TB case finding a challenging job. There is a risk of tuberculosis transmission because most of the ART centers do not have cross ventilation, and since they are congested OPDs, the workload is more, so risk of TB transmission, so infection control becomes a challenge. And next important is INH stockouts. Now there is a impact for TB, scaling up of 3HP for tuberculosis prevention, which includes INH and rifampicin for 3 months, which is being started. The project is run in 13 countries and India is amongst them. Next. So to summarize, HIV tuberculosis infection continues to be a leading cause of morbidity and mortality. The one-step model is adopted by Indian program to strengthen the HIV TB integration. Most important aspect of this program is intensified case finding, which is successfully implemented in India. Tuberculosis preventive therapy via IPT is currently exceeding the global uptake as compared to other countries. Co-location of uh, co-location to strengthen the integration of organizational HIV/TB integration has been implemented already. Vulnerable population has been targeted for TB/HIV services with much success. However, the challenges are still existing that includes IPT stockout, adherence, infection control, and hence the new strategies are needed to have further successful program. Last but not the least, in December 2020, 1st December 2020, which is the World's AIDS Day, there is a theme is to eliminate HIV and AIDS. And with this assumption, we have to also assume that even tuberculosis also should get eliminated. And the National Elimination Program of Tuberculosis, which is for by end of 2025, we have to eliminate, which for this we have to work very hard. Now expected in 2019 there was 63% reduction of TB deaths. In 2020 75% reduction of TB deaths was expected. But why this is not achieved? Because there is a late diagnosis. But only 44% of male HIV tuberculosis were not diagnosed in 2019, and therefore early treatment was not possible. Now, very important point about 2020 is the impact of COVID on HIV and TB. Because of COVID-19 pandemic, there was reduced access to care for both indoor as well as outpatient services, which increase the risk of tuberculosis in pale HIV. And hence, we need to expand and strengthen the integrated services all over India for TB and HIV. Thank you.